Good evening. First of all, I would like to welcome all the attendants to today's webinar of the Gerhard Center webinar series, The Aftermath of COVID-19, the New Social Impact Ecosystem. It's without a doubt a great honor to be introducing such an influential figure. I almost can't believe it. He's the most renowned person in the world of public health, Professor Sir Michael Marmot. Literally, he wrote the book on social determinants of health in 1998 among a long list of books and citations like The Health Gap in 2015 and The Status Syndrome in 2004. Sir Michael, as you may all know, is the director of the Institute of Health Equity, University College London, and a professor of epidemiology in the same university since 1985. Sir Michael was knighted by Her Majesty the Queen of England in 2000 and received honorary doctorates from 18 universities for his work on social justice and health and epidemiology. He belongs to an inspired, massive list of organizations that I'm honored to mention only some of it, as it's going to need more than the session time to go through them all. He chairs the Commission of Equity and Health Inequalities in the Americas. He was the president of both British Medical Association and the World Medical Association. Professor Marmot is also the advisor to the WHO Director General on social determinants of health in the new WHO division in healthier population. It's also quite astounding to know that according to the Google Scholar citation ratings, Sir Michael is the 59th most cited person in the world, with almost 250,000 citations to his name on Google Scholar, bearing in mind that Albert Einstein sits on number 55. We are privileged to welcome Professor Sir Michael Marmot here with us from John Gerhard Center at the American University in Cairo, Egypt, a land which has a prosperous past, struggling present, but most importantly, a hopeful, thriving future, where social justice is no longer considered a luxury, but a necessity. Sir Michael is here to talk to us about social justice and health equity. Please allow me to welcome Professor Sir Michael Marmot.
Thank you, and it's a pleasure to join you. I'll share my screen.
Thanks, Steve.
I've given the title of my talk today, Build Back Fairer, for two reasons. One, that I'll show you. You probably can't read this properly, but I'm so excited. It's a report on a desk in the WHO office in Cairo, and it's called Build Back Fairer, Achieving Health Equity in the Eastern Mediterranean Region. So WHO, EMRO, Eastern Mediterranean Regional Office, commissioned me to chair this Commission on Social Determinants of Health. And on the 31st of March, we will publish this report. So this is, I say, it's very exciting. This is the first physical copy that I've seen printed out. We're still finishing the report, but it will be published on the 31st of March. So I'll come back and talk to you about it some other time. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. And in fact, in that commission report that I showed you the cover of, we will say a great deal about the conditions that made people sick, somewhat less about the health care system. We need a healthcare system when we get sick. Universal health coverage is absolutely vital, but I want to discuss the conditions that make people sick in the first place. When we look at COVID-19, it has, of course, had global impact. This was a report early on in the pandemic from the United Nations Development Programme, looking at the global burden of disease. So this was, as say, early, less than a year ago, but early in the pandemic. And there's stylized the global deaths from transport, from HIV/AIDS, self-harm, malaria, and whoosh, that's COVID-19, actual deaths. It went down, and then, of course, it went up again. The United Nations Development Programme produces a Human Development Report, which has a Human Development Index, the HDI. The HDI has 3 components: life expectancy, education, and gross national income per person adjusted for purchasing power. So this is the global Human Development Index. 1990, 91, it goes up. Some years it goes up a little more slowly than in other years, but pretty much it goes up. Here's the global financial crisis from late 2007, 8, 9, and the rate of increase of the HDI slowed a bit, but then recovered. And it's well to bear that in mind. This was the global financial crisis, and that was the impact on the HDI. And here is the estimated effect of COVID-19. Absolutely dramatic. And as I say, this was early in the pandemic. The Human Development Programme, the UN Human Development Programme, also produced this graph. This is the lowest socioeconomic group in Puerto Rico saw excess deaths from Hurricane Maria much more than other groups. So Hurricane Maria hit Puerto Rico September 17, and these are the excess deaths: lowest socioeconomic group, medium, and highest. So you get a big external shock like a hurricane, and it doesn't affect people equally. The lower the socioeconomic group, the bigger the effect. And so it is with the pandemic. Build Back Fairer, the second reason that I'm talking about it, is the name I gave to a report in England. And now I'm going to talk about the experience from England. So one country, because we have very good data, and there's a lot we can do. In February 2020, 1 year ago, 1 year and less than 1 month ago, I produced a report, Health Equity in England, the Marmot Review 10 years on. So to go back, I chaired the WHO Commission on Social Determinants of Health. We reported in 2008. And then the British government, Prime Minister Gordon Brown, asked me to conduct a review of health inequalities in England. The question was, how could we apply the findings and recommendations of your global commission to one country, England? And I produced the Marmot Review, published in 2010. So in 2020, we look back at the last 10 years, what had happened. And my simple summary was, we have lost a decade, and it shows. If you look at life expectancy in England, it had been increasing about 1 year every 4 years in women and in men. I've taken this back to 1980. If I went back to 1890, we would have seen the same thing. For more than 100 years, life expectancy was improving about 1 year every 4 years. And then in 2010-11, that curve changed dramatically. The rate of improvement slowed, and the improvement just about ground to a halt. There was a new government elected in the UK in 2010, a Conservative-led coalition government. They were a bit sensitive. Surely, they said, you can't be saying it was anything we did that led to the slowdown in improvement. Well, we need to look at it. One thing people said was, well, maybe we've just reached peak life expectancy. It's got to stop improving sometime. So we looked at what had happened in other countries. We looked at annual life expectancy improvement in weeks between 2011 and 2017. And there's Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, all of these countries. And there's the UK. The only rich countries that had a slower rate of improvement than the UK were Iceland and the United States. So no, we had not reached peak life expectancy. Other countries were still increasing. We weren't. The second feature of health, and this is before the pandemic, this is February 2020, before the pandemic hit. We look at inequalities, classify people by where they live, and classify the area where they live by degree of deprivation. And these are deciles, 10%. So the most deprived 10% have shorter life expectancy than everybody else. But inequalities are not confined to poor health for the poor, but it's a social gradient. You can see the less the deprivation, the longer the life expectancy. The gap between the least deprived 10% and the most deprived 10% was 9.5 years for males, 7.7 years for females. And that gap got bigger over the 10 years. The gradient, the social gradient, got steeper. And when we look regionally, this is women, but it's a similar picture for men. For the least deprived 10%, it doesn't much matter which region of England you live in. Life expectancy was improving a bit. So if you're rich, it doesn't much matter where in the country you live. For the most deprived 10%, the regional differences are much bigger. And life expectancy for the poorest 10% was going up in London and going down in the rest of the country. So 3 features of health in England before the pandemic: life expectancy had stopped improving, inequalities in health were increasing, and health for the poorest people was getting worse. If you agree with my proposition that health tells us something fundamental about how well a society is doing, it means society had stopped improving and inequalities in society were increasing. Not a good situation. Now, in 2010, in the Marmot review, which we called Fair Society, Healthy Lives, I had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4, really crucial, in a rich society, everybody should have at least the minimum income necessary for a healthy life. Healthy and sustainable places and communities in which to live and work, and taking a social determinants approach to prevention. Let me illustrate what I meant by the last. In England, if people followed the healthy eating guidelines, for those in the most deprived 10% of household income, to eat healthily, to follow the healthy eating guidelines, they would have to spend 74% of household income on food. If they spent 74% of household income on food, who's going to pay the rent? And if they paid the rent, who's going to buy children new shoes when they need it? So what happened in 2010? As I said, it was a conservative-led coalition government, and they had as their number 1 objective, austerity, roll back the state. And they did. In 2009-10, of total GDP, gross domestic product, 42% went on public expenditure. And true to their ambition, they reduced that year on year. So by 2018-19, that 42% had become 35%. They did roll back the state, and they did it in a most regressive manner. This is spending by local government per person. The grey bars is total local authority spending by level of deprivation. So in the least deprived 20% of areas, spending went down by around 16%. And then the more deprived the area, the greater the reduction. So in the most deprived areas, it went down by 32%. Now, the greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could such a regressive approach to public spending have an adverse impact on health and health inequalities? Yeah, I think it could. And the policy didn't work in its own terms. The supposed reason for this austerity was to get economic growth. Well, look at wage growth in OECD rich countries from 2007 to 2018. There's the UK. The only countries that had slower wage growth in that period were Greece and Mexico. Portugal and Italy did badly too. And then all these other rich countries did much better. They had positive wage growth. So we suffered austerity. It was done in a regressive way, and it didn't work to get growth in wages. Early childhood. Poverty in childhood is a relative measure. It's living in a household at less than 60% of median income. Before housing costs were taken into account, 18% of children were in poverty in 2010-11. After housing costs, because housing is so expensive, that went up to 27%. And over the decade, 27% rose to 30%. So an increase in child poverty. And changes to fiscal policy, changes to the tax and benefit system, introduced between 2015 and 2017. Let's look at working age families with children by level of deprivation of household income. So those in the bottom 10%, as a result of changes to taxes and benefits introduced by the Minister of Finance, would have a drop in income of 15%. The next 10%, a drop in income of 12%, and so on. The richer you were, the less the drop in income. So the Minister of Finance was taking money away from poor people, and the poorer they were, the more money he took away from them. And the cuts to services in local government, of course, can have big effects. So this is counseling services for young people, get young people off the street doing interesting things. And after a small dip, violence increased. So there was violence, small dip, and then it increased. That's the most deprived area. That's the least deprived. So a clear social gradient in violent crime, but the greater the deprivation, the greater the increase in violence. So all of that is what we reported in February 2020, the 10 years on from the Marmot review. I didn't wait 10 years for my next report. I only waited 10 months. And in December 2020, we published Build Back Fairer, the COVID-19 Marmot review. We wanted to see what the pandemic did to the inequalities that we identified. And as I said at the beginning of this talk, Build Back Fairer is the title we're giving to our commission in the Eastern Mediterranean region on social determinants of health. So if we look at the social gradient, there's mortality from all causes by level of deprivation. I showed you life expectancy before, but it's the same gradient. And here, the pale green is mortality from COVID-19. The inequalities in mortality from COVID-19 are almost exactly parallel to the inequalities in mortality from all causes. It means that the causes of inequalities in health more generally apply to COVID-19. People in more deprived areas are more likely to get it, in part because of exposure to infection in frontline occupations, living in overcrowded, possibly multi-generational households. That was men, this is women, similar. And when we look at ethnic groups in England, white is the comparison group, Black African, females and males, big increase in Black African. And then it's asking how much of that increase can be attributed to geography, where people live. And you can see that much of it can be attributed to geography, which in turn is related to deprivation. And then other socioeconomic characteristics. Interestingly, prior ill health does not make much of a contribution to the excess in Black Africans living in England or Black Caribbean. It does make some contribution to the excess in Bangladeshi. You can see it's reduced further by adjusting for prior ill health, and Pakistani. And then some excess in Indian, but not as big as in Pakistani or Bangladeshi. So we've got the social gradient by level of deprivation, and then we've got ethnic differences, much of which can be linked to deprivation and other socioeconomic characteristics. And when we looked, I'm being critical of my own country, but happily I'm allowed to. When we look at excess mortality, so excess mortality, the concept is how many deaths would you have expected in 2020 based on the previous 5 years? How many were there in practice? And the difference is the excess. And the excess was higher in England than in Scotland, higher than in Wales, Northern Ireland. In fact, in the UK, the excess was higher than in any other rich country. Most of us looking at the US say their management of the pandemic was a disaster. The excess mortality in the UK was higher than in the US. So I asked, remember I said that health is a measure of societal success. Pre-pandemic, life expectancy was stalling. Inequalities in life expectancy were increasing. Life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries except Iceland and the US. And during the pandemic, we had the highest excess mortality. And I asked myself, what's the link between these two? Poor governance and political culture, social and economic inequalities increasing, reduction in spending on public services. I showed you the regressive nature of the cuts. And we weren't very healthy coming into the pandemic. And then during the pandemic, the inequalities got worse. This is falling behind at school. In the least deprived areas, children not at all behind, 1 month behind, 2 months behind. In the most deprived areas, children 6 months or more behind, 5 months or more behind. So you see this spreading out of the gradient. And low-income workers most likely to be in shuttered sectors. So the lower the income, the more likely was that sector to be closed down, hospitality and the like. So low-income workers either had to go out to work in unsafe work where they were exposed to the virus, or their place of work was shut down. An historian, Lord Peter Hennessy, contacted me, and he said, your Build Back Fairer report is a beverage for our time. I don't know if the name Beverage Report means anything to you, but during World War II, William Beveridge, produced a report, in a sense, asking the question, what are these men fighting for? What can they look forward to when they come back to domestic life, when the Second World War is over? And he said, there are 5 giants on the road to reconstruction, and want is only one of them, in some ways the easiest to attack. The others are disease, ignorance, squalor, and idleness. So my approach to beverage, want, in a way, is relative deprivation. I talked about being in a household at less than 60% median income, a relative measure of poverty. Squalor is absolute deprivation, homelessness, poor housing quality, literally not having enough money to eat. Ignorance, well, education, we know, is very important. And idleness, I talked about the importance of work, dealing with unemployment. So I think of these 4 giants, relative deprivation, absolute deprivation, education, and good work, as leading to the 5th, disease. So my recommendations, remember, health is a measure of societal success. And I said, look at our executive summary of the Build Back Fairer report for specifics, which are based around our 2010 report. Give every child the best start in life, education, employment and working conditions, having enough money to live on, healthy and sustainable places, and taking a social determinants approach to prevention. So remember, health is a measure of societal success. We have to deal with poor governance and political culture, the increase in social and economic inequalities, the reduction in spending on public services, and that we were unhealthy coming into the pandemic. So my number 1 recommendation is put a fair distribution of health and well-being at the heart of all government policy. And I'd like to suggest, you said that Egypt had a rich past, an uncertain presence, and you hope for a good future. I'd like to suggest that what I've just said for my own country might well apply to Egypt as well. Thank you.
Thanks to you, Sir Marmot, for the presentation, and I think we can start taking questions if you're ready. Let's go. Yeah. Okay. Okay. The first question we had in mind: the ultimate purpose is to achieve social justice. However, building a compelling economic case is the mean to this end, and a huge part of a challenge against achieving real equity is the different needs of special groups like elderly, like people with disability. So in the case of people with elderly and people with disability, for example, they require like extra care, extra services, and definitely additional cost despite being economically inactive. So how can we economically justify to the governments the value from investing in the different types of supports and care for these vulnerable groups, which could be a major challenge against developing countries who had limited resources in achieving real social justice, because this we face like every day, justifying investing in certain areas. Thank you.
Yeah, it's a very important question. And so let me start off with my own country, a rich country, but thinks of itself as a poor country. I mean, the way it's dealing with its public finances, it thinks of itself as a poor country and says, oh my gosh, the cost, I mean, the economic cost of the pandemic was enormous. So the politicians are behaving as if we have no money. And I say, wrong question. Don't ask how much it costs as the first question. As the first question, ask, what do we want to achieve as a society? What's our societal goal? If you think that saving money is more important than dignified life for older people, then by all means, go and save money. But then you're saying that a dignified life for older people doesn't matter. We'll throw them on the scrap heap. Is that your priority? So my reaction to government is, well, come out and say it. Say it. Go on, say it. We don't care about older people. We're going to throw them on the scrap heap because it's not economically worthwhile to provide the conditions for a dignified life. Say it. Be out there. Say it. Now, at the other end of life, it's easier because you can make the economic case that investing in early child development is good economics. That's not the case I make. The case I make is a moral one, that it's the right thing to do to provide a good future for our children. But it's easy enough to make the economic case. But as you said in the question, it's much harder with older people. That's why we need to make the moral case. That's us you're talking about. That's people, today's people in the future. And we just want you to be very clear that you're saying we're throwing them on the scrap heap. Now, we know there's always limited money. That's always the case. But I mean, in our EMRO Commission, we will talk, and I know this is close to your interest, we will talk about the importance of social protection and implementing a social protection floor, which should apply through the life course.
Okay, thank you so much. Just a little additional question. Do you believe in social return on investment? Should we calculate the social return on investment?
Well, yes, of course we should. But I wouldn't do it in a narrow economic way. I'd do it exactly as you said, the social return, not the economic return. So in other words, it's very important to have good monitoring systems. So we know, are we doing any good when we spend money? Are we improving the quality of life of people and their health? So it's very important to have good monitoring systems so you can evaluate what the government and others and civil society, the voluntary sector, local government, the healthcare sector, you can evaluate what impact they're having. So yes, getting measures of social return is vital. It's part of good management.
Okay, thank you so much. Another question. During your vast work in creating, promoting, and advocating social justice in health, what were the most inspiring examples from the integration between NGOs, private sector into this cause, and how you can advise governments to the best benefit from the local NGOs and private sector?
Well, let me talk about NGOs first. I've often quoted my friend and colleague Mirai Chatterjee from the Self-Employed Women's Association, which began in India in the state of Ahmedabad, the state of Gujarat, in the city of Ahmedabad in Gujarat, and has now spread to other Indian states. And it is essentially a trade union for self-employed women. Now, self-employed women sounds like journalists and lawyers and doctors and whatever. But in the context of India, these are people who sit and sell vegetables in the marketplace. They clean streets, they stitch a few clothes. You know, they're the poorest, most marginal people in India. And when we began the Global Commission, WHO Commission, I said that if governments didn't care, then we were finished. What could we do? And Mirai Chatterjee said, no, if governments don't care, then civil society organizations have to do it. And so the Self-Employed Women's Association set up a bank, Saver Bank, to to give microcredit to these women. It set up child development clinics to look after their children. It set up health clinics. It helped with housing. It helped with their legal problems. And now it's helping with pensions. So they're actually pushing the government to follow their lead. With the private sector, we've had less success. That said, in the UK now, we are talking with a couple of large private sector organizations about them taking on social determinants of health and health equity, because the private sector is very important. I mean, take food. For those of us who don't grow our own food, if we live in cities, we have to buy food. We tend not to buy it from the government food supply. We buy it from the private sector. Without the private sector in food, we'd all starve, the people who live in cities. So the private sector is very important. And it's important in at least three ways. Firstly, they produce products, which those products can make us healthy or make us sick, like food, can be good for us or bad for us. Second, they employ people, can be good for people to be employed, much better than unemployment, but the quality of work really matters. And thirdly, they have an impact on the community, environmental impact, social impact, economic impact. So for all three reasons, the private sector is very important. It's very important to engage them. But whereas I've got good examples of the voluntary and community sector getting engaged, I have fewer good examples from the private sector.
Expected. Thank you so much. We have another question from Dr. Raymond Sainer. Please unmute yourself and ask your question, Dr. Raymond. Dr. Raymond?
I'm just trying to manage my technology here. Thank you for your presentation. It was very interesting, and I just wanted to come back to what you said before about monitoring, the need to monitor our governments. I fully agree with you. The question is, of course, how and what could be the consequences of monitoring. I gave the example in my little chat saying, if we have a leader such as the former president of the US, Mr. Trump, who did not consider COVID as a serious threat. And hence, by delaying attention given to a pandemic, you can say there's a causality that goes with it that caused a lot of deaths and suffering. But what can we do other than just not elect them again? Is there a way to, to monitor and to hold them accountable?
Good question. And yes, of course, there is a way to hold them accountable other than election, but it takes a mature government to, as it were, hold itself up to account. Most countries in the world have committed to the SDGs, the Sustainable Development Goals. If they were serious about measuring progress on the SDGs, that is a way of measuring the social determinants of health. At least 11, maybe all, but at least 11 of the 17 SDGs, I would say, are social determinants of health. And governments have committed themselves, right? They've committed themselves, do it, set up proper monitoring systems. And it may be uncomfortable. Well, that's what living in an advanced society looks like. You do get found out. It may be uncomfortable, but we should be pushing to hold governments to account. As I say, that's what living in an advanced society should be like. And it's a way society improves. I mean, there's discussions for reasons that you can well imagine, about the future of democracy. And it wasn't only the election of Donald Trump that led people to want to have those discussions, but both in the US and the UK, learned scholars were publishing books from Harvard, from Cambridge University, about how democracy dies and the end of democracy. Well, one way it dies is failure to hold people accountable and not being accountable. And the real worry was that Donald Trump completely disdained the facts. He thought the facts were his enemy. So, I mean, my own feeling about Trump, for all his other sins and shortcomings and everything else, the one I can't forgive him for is his complete disdain for the truth. If lying becomes the currency, then it's very difficult to make progress. That's part of holding people accountable, is tell the truth. I've had senior politicians in my own country say, you talk to the public all the time. What can you tell us? And I say, I'm sorry, I'm no good at telling you how you should communicate. I can tell you what I do. And what I do is tell the truth, show the evidence, which is what I did this afternoon, and try and engage people in the discussion of what kind of society we want, based on the truth and the evidence. So the monitoring and evaluation and holding to account is absolutely crucial.
Okay, thank you, Doctor. We have another comment from Dr. Vinit Sharma. Please unmute yourself and ask your question. Dr. Vinit Sharma?
Thanks for the wonderful presentation. My basic question is that, that we are seeing lack of public spending as far as, the governments are concerned, in various parts of the world, in infrastructure, as far as healthcare is concerned, as far as, with education and all, that is leading to this sort of, repression, basically. And what are your views regarding, globalization and immigration policy, that is being widely adopted in the world, because it is leading to, the carrying of, workers which carry, poverty and disease with them, and COVID is the real, risk factor with that, because with the, with this airplanes and all, people can carry, can get from one place or the part of the world to the other part of the world, very quickly, and with that carry the disease, and with that, because of this massive, corporate culture, in the world, because of which we are going through this, race to the bottom, as far as taxes are concerned, and proliferation of big tech firms, which is causing, stock market bubbles and etc. So, but the real wages of the, individuals and workers are getting suppressed, so it is a massive risk factor as far as, so can you elaborate on that,
Yeah, if I thought the kind of recommendations I've been making were only applicable to rich countries, then I wouldn't have been doing what I've been doing, which is I chaired a commission for the Americas. So it wasn't just for North America, but for Latin America and the Caribbean as well. Huge inequalities, lots of poor people. And now this commission, which, as I said at the beginning of my talk, in the Eastern Mediterranean region of WHO for North Africa and the Middle East, where you have some of the richest countries in the world based on gross national income per person, and some of the poorest countries in the world, and then countries like Egypt, which are somewhere in between. And we think our judgment is there's much can be done at every level. If you're a poor country, a medium country, or a rich country, there's much that can be done. Now, it takes political will. You have to want to do it, and that's key. but there's much that can be done. I mean, after the Global Commission, the WHO Global Commission, to come back to my colleague Mirai Chatterjee in India, and she said that the government of India, it was almost as if they had been working their way down through the WHO Commission's recommendations and implementing them. The Rural Employment Guarantee Scheme, for example, it was essentially a universal basic income for rural workers. It guaranteed them, I think, 150 days or something like that, employment a year. Food subsidies, involvement in education. I mean, many of our recommendations, now there was a change of government in India and they stopped doing that, but it shows, firstly, how important politics is, but how these things can be done. And when we look at a country like Egypt, for example, when I was really struck when we began the Global Commission at how rapidly Egypt's childhood mortality had improved, how rapidly Egypt's infant mortality had improved, and that you can get rapid improvements really quickly. So I look at this and say, I've got evidence-based optimism. I look at the evidence of how quickly there can be improvements, and I think it's never hopeless. It may be difficult. There may be governments that seem to be dragging their feet and not interested, but then we need to find the way in. If national government is not doing things, local government, the voluntary sector, and use the evidence, and that's where the accountability comes. So whatever, whether it's a very poor country, a middle-level country, or a rich country, there's always more that can be done.
One more question, please. I think two. One? Okay. How or which entity can assume the full responsibility of achievement of social justice in health? What is the best governance model for it? Because there is no, like, different stakeholders might seem responsible for such a target. And here in Egypt, for example, they are not normally fully integrated. So from your opinion, how can we govern this?
One of the things, if you look at our huge report that will come out in 2 weeks' time on the 31st of March, and it's huge, so don't be put off by how big it is. But we've tried to bring the evidence together. And one of the things we're saying is there isn't one model. We've given you the evidence. We have a whole chapter on governance, but we say there's not one model. It has to be interpreted differently for different countries. And so I don't have one simple answer of the right level of governance. In Britain, for example, to come back to my own country, I've shown you the rather disappointing response from the national government from 2010 to 2020, but the English city of Coventry declared itself a Marmot city. Marmot city, wow. They didn't do it. I mean, I didn't ask them to do that. They said, we're going to take your 2010 report and we're going to use it as a basis for planning what happens in the city of Coventry. And then Greater Manchester, everybody in Egypt's heard of Manchester because of football, Manchester United and Manchester City. So you know about Manchester. Greater Manchester said, well, if Coventry can do it, we'll become a Marmot region. So we've got local government, cities all across England coming to us saying, please work with us. We want to be Marmot cities or Marmot regions. Wow. So the governance model that's been working in the UK has been not at the national government level, but at the city level. Now, Wales and Scotland, it's a bit clear whether they're separate countries or not separate countries. That's a big political question. But they've been very enthusiastic. So Wales and Scotland have been enthusiastic, and cities and regions within England have been enthusiastic. So one governance model is work with local government. But in Costa Rica, the national government has been very enthusiastic. In Brazil, before the current government, but the previous government of Lula and Vilma were very enthusiastic at the national level. Bolsonaro has not been. Lula's been released from prison. He may campaign for the next presidential election. If he gets re-elected, I would expect there to be renewed interest at the federal level in Brazil. But in the meantime, there's a lot of interest in Brazil at city and state level. So there's not one governance model. It depends on the particular situation. And, so in the UK, when people say, aren't you frustrated that no one's listening to your report? And I say, they are listening. Coventry is a Marmot city. Greater Manchester is a Marmot region. We're working with Cheshire, Merseyside, and North East England, and they are listening. It's just the national government that hasn't been taking it seriously. That said, in the Parliament, an opposition member of Parliament asked the Prime Minister, are you going to implement the Marmot Build Back Fairer report? And the Prime Minister said, I admire Michael Marmot. We've worked together for a long time. I was slightly confused by that comment. And please be assured that we will, as we rebuild, implement his report. Okay, well, good. And then the leader of the opposition made a big speech about his plans for the future, citing my report. So we've got both the leader of the government and the leader of the opposition both claiming they're going to use my report. Now, I don't know whether either will, so we have to see what happens. But in other words, we're becoming part of the political debate. And there isn't just one answer to the question of what's the appropriate level of governance. We're very happy working with cities. If we get a national government that's friendly, great, then we'll work with national government. And the reason I'm citing this is because if it's a conservative government who want to do this, I'll work with a conservative government. If it's a centre-left government that wants to do it, I'll work with a centre-left government. I shouldn't let my own politics interfere. Whichever one I prefer is not the issue. The issue is, can we get the government of the day to work on creating fairer societies with better health for all based on principles of social justice?
Thank you so much. I know we're not allowed to take any more questions. We are waiting all for the coming report in the coming 2 weeks. And by the way, just one more comment. If I had this crossword from the Italian magazine where they said about you, the founder of social epidemiology, I would have answered correctly. I know the answer now. I wanted to say it since the beginning, but I kept it to the end. Thank you so much for this wonderful, amazing, insightful webinar. Thank you.
My pleasure. My pleasure.
Thank you, sir. Thanks to you. Okay, in the end, I thank Professor Marmot for a very insightful webinar and a great discussion. Thank you all for your participation in this webinar. And we look forward to seeing you all on Wednesday, March 17th, the impressive of civic engagement in higher education. Moderator will be Dr. Simon Gray, a program officer of the Global Liberal Art Alliance, Great Lake College Association, United States, with panelists from HEC University, Ghana, Universidad San Francisco de Quito, Ecuador, and University of Cape Town, South Africa. Have a lovely evening, everyone. and thanks for your attendance. Goodbye.
Thank you, Dina.
Thanks to you, Doctor. Thank you.
ميرسي قوي. باي باي.
حضرتك مع السلامة.